From June 7 to 21, step by step, I presented the key points of the new 2022 guidelines for heart failure from the American College of Cardiology and the American Heart Association. The compilers of the guidelines, the list is long. The titles of the participants should inspire awe and respect. They consider a breakthrough in this part of cardiology. The topic is undoubtedly relevant, since there is no such heart disease, such heart disorders in other diseases that would not eventually lead to heart failure. There are two key points in the recommendations: new classification of heart failure and quart therapy for heart failure. The new classification is pseudo-new for me, since the classification ABCD has remained. It's just that the compilers of the recommendations put their semantic content in front of the letter designations, namely the risk of heart failure, pre-heart failure, symptomatic heart failure, and progressive heart failure. In this way, in their opinion, the classification has become closer, as it were, for primary care physicians and patients with heart failure themselves. I personally would not belittle these doctors so much. Yes, and to patients, I am convinced that these doctors, despite the letter designations, are very convenient for me, explain to their patients what kind of heart failure they have and how to deal with it. But God be with them, so be it, despite the fact that the letter designation have been preserved. As far as heart failure quart therapy is concerned, to me it's like a stolen Maastricht consensus quart therapy idea to peptic alkals. At the same time, the authors robbed the financial interests of pharmaceutical dealers into this therapy. I will not list the 4 groups of drugs they recommended for the treatment of heart failure. You will find them in my previous videos of this. I will pay attention only to the drugs of the first recommended group. This is a new class of drugs that have appeared more recently, inhibitors of sodium-glucose transporter 2. No, of course, they can be good, but we still need to prove that they are better than the same angiotensin-converting enzyme inhibitors, for example. Here, it seems to me, I repeat, the pharmaceutical business has done a good job in promoting its interests. The main thing for me is, and by this I ask you to treat any recommendations coolly, that the doctor treats the patient, but not the disease, and even more so clinical syndromes, which include heart failure. It is up to the doctor, and not recommendations, to decide what kind of therapy the patient should have: quart, triple, double, or no drugs at all, but only recommendations on lifestyle or something else there. Guidelines are always educational, partly recommendatory, but never rigidly prescriptive. I understand that I have already expressed myself quite clearly and hope that you, colleagues, always make decisions on how to act, including in cases where the patient also has heart failure.